One of the issues was informed decision that was brought forward, that everybody should have informed decision before PSAs. And maybe you could discuss that for a second. Then the other thing you said is that we have a simple PSA level of 1.5 rather than percent free PSA, complex PSA cutoff of 2.54, and all these other things that confuse you guys.
Sure.
So
Sure.
tell us about this informed decision.
Sure.
And then just finish up saying you're unique the way you feel. What about other family practice docs you talk to?
Well, absolutely, and that's a lot of questions. So let me try to get to all of them the best I can. First of all, if you look at the guidelines, they all talk about shared decision making. Just as you were saying, informed shared decision making, same thing. There are three tenets of shared decision making, and in those tenets, you need to inform the patient, you need to elicit their opinion, and you need to guide them on the right thing to do. Mm-hmm. And Dan, you said this to me about 2 years ago, and I've quoted you 1,000 times now. You said, Matt, and you're about as well educated in this as anybody. You told me it would take 23 minutes to do shared decision making in the world of prostate cancer for a patient or prostate screening. And so let's look at how that pertains to the people using the PSA. The bulk of PSAs, as we already said, were primary care. So do I have 23 minutes per patient per exam when I'm getting a PSA to have that kind of decision or to that kind of discussion with a patient when I'm not even that well trained in urologic disease? I remember in primary care, I'm the master of nothing but the knower of everything. I have to deal with all this stuff, so I need a simple way to do it. So the bottom line is when the task force said shared decision making, when the AUA said it, when every group said this, they were wrong. They didn't understand their audience. Now, how do we move forward from that? What primary care need is a simple way to do this without missing anything. If we go back to identifying prostate cancer patients when they're metastatic, then we've done the wrong thing. That's the bottom line. We need to catch them early on with this. How do we do that? We educate them. And with the 1.5 number, and you and I have worked on this now for a while, that's going to be our answer. And 1.5, first of all, is not that common. The study I did out of some data from the Bioreference Lab, we looked at 217,000 PSAs that were drawn in 1 year for patients between the age of 40 and 75. And the reality of it is, in a screening population, 73% of the PSAs were less than 1.5. So you
only have to really work with about 30% of men, and that's where the informed decision comes in.
That's where it comes in. So now we bring our population to something we can handle. And there's something that you taught me years ago, which was we should be using the PSA as a vital sign. All right, it's a number. We don't treat a number, we use a number and evaluate it and take care of it appropriately. So if I get that PSA and it's elevated, 1.5 or more, and I use it as a vital sign, as you've suggested, then I go into the shared decision-making with the patient, and now I can really do something and say, look, this is where your risk goes up. Maybe we need some more information. I could refer you off or get a biomarker, and we can catch that patient who's at risk for that aggressive life-threatening disease.